bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAPHC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAPHC Tweets and using the hashtag CAPHC Presents. All of our webinars are recorded and can be found on the CAPHC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAPHC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive. All right, hello everyone, and welcome to today's episode of CAPHC Presents. I'm Doug Maynard, the Associate Director at CAPHC, the Canadian Association of Pediatric Health Centres. And today we're going to talk about how to succeed with your ideal for change, reflections on effective child health advocacy. And it's a great opportunity for us at CAPHC to work with our partners over at the Canadian Paediatric Society and showcase some of their work and bring some of their leaders to our webinar program to sort of share their experiences on one of the areas of children's healthcare that they're very effective at, and that's advocating on behalf of pediatricians and children's health services more broadly. They're going to be talking about the Are We Doing Enough report that the Canadian Paediatric Society puts out biennially. So it's and that's a great report that talks about different policies across the provinces and how they're doing to support children's health care. So it's my pleasure to welcome two leaders from the pediatrician community. Dr. Michael Dickinson is a community pediatrician and the head of pediatrics at the Miramichi Regional Hospital in Miramichi, New Brunswick. And also joining him is Dr. Andrew Link, who is the newly appointed, well, we were just saying he's not so new anymore, but we'll call him recently appointed Chair and Chief of Pediatrics at the IWK Health Centre and Dalhousie University in Halifax. Prior to that, he had practiced in community pediatrics in Cape Breton for over 25 years. He is the past president of the Canadian Paediatric Society, where he also chaired the Advocacy Committee for 10 years. And Dr. Michael Dickinson is currently chairing the Canadian Paediatric Society's Advocacy Committee. So without any further ado, it's my pleasure to hand the virtual podium over to, I think first up, we're going to hear from Dr. Andrew Link in Halifax. Over to you.
Thank you, Doug, and welcome everybody. And I'm excited and pleased to be able to present with my good friend and colleague, Mike Dickinson from New Brunswick. And we're going to split this in two, the presentation. I'm going to be talking a little bit about some case studies and principles that I've learned over the years about effective advocacy that makes a difference. And Mike is going to talk on a high level and review some of the issues about with our status report from the Canadian Paediatric Society and how we've developed and used that and continue to use that through the years. So we're going to go on a little journey. This is a lovely picture of the Bredor Lakes in Cape Breton, where I used to live and still go back and help work. And it's just on the home where Alexander Graham Bell had his home, looking over to the bay. And you can see the picture of my wife and I boating there. We're actually we're pediatricians, so we're just in the canoe, but the orthopedic surgeon has his big sailboat there anyway. But it's a lovely part of the world. So I have no disclosures or conflicts of interest. And as I said, I'm going to just talk a little bit about how to choose and pursue focused advocacy issues and using some case studies and some of the lessons learned. This is also Cape Breton. This is Ingonish, a little further north from Bedeck, and where my wife and I often go, and lovely hiking and biking and beaching and everything else up there. George Bernard Shaw wrote this several years back, and I think all of us who are advocates challenge the status quo and ask that question, why not? So there's 12 things that I'm going to go through of lessons learned, and I'll review them very quickly now, and we'll also review them at the very end after we go through 3 case studies. So the one is having, if you're going to pick a topic, you want to make it focused, and you have to take the long term. One thing about advocacy is persistence and not giving up, and having a long term. It sometimes takes time to change things, and you need patience. When you are trying to change things, you want to have evidence-based information that you can persuade people, but you also need, and I've learned this through the years, the human story that you attach to it. The PowerPoints that are all graphs and numbers will make everybody go to sleep and may appeal to the rational minds, but not to the human heart. So you do need those human stories as well. You need to decide who are the decision makers and what pressures do they have. For example, if it's government, do they have an appetite for that right now? Is it close to election time when they're distracted? Are there budgetary pressures? There are always budgetary pressures, but some things can be solved just with legislation as well. For example, and Mike will talk about this later, I'm sure, the booster seat legislation, for example, doesn't cost really any money. Very important to understand the opposition to your idea for change. What are their fears? You know, is there money involved? Is there influence and power involved? What are their interests? Sometimes you can deal with these by compromising and coming to a halfway agreement. Sometimes you just have to work around it, but it's very important to understand it. Always be prepared for pushback or indifference. I think indifference is sometimes worse than pushback, because at least when you have pushback, you know what you're up against. And it's very important to identify your allies, your champions, have a common coalitions, which is always more powerful. And I'll tell you, you don't always know who your allies are. And I'll be explaining something about our youth health centers that we got going in Cape Breton. When we were first trying to do surveys in all of our high schools that talked about and asked questions to the teenagers anonymously about sexual practices and things, one of our high schools where there was a lot of teen pregnancies was a Catholic high school run by the nuns for girls only. And I said, there's no way that the principal, who is a nun, is going to allow us to, put that survey through. But you know what? She was one of our strongest champions. And she recognized the issue of unplanned pregnancies and the devastating effect that they had. So you can be pleasantly surprised, and you don't know unless you ask. Harry Truman, former president of the United States, once said, "There's no end to what you can accomplish if you don't care who gets credit for it." So I think it's always important, especially if there's government people involved or people who are budget people or administrators. It doesn't matter to me. I give them all the kudos, as long as at the end of the day it gets done. When you're an older person sitting in your rocking chair in your 80s, watching the clouds go by, you'll know that at least you had a part in something, and that's all you really need. The other couple things about advocacy and the 12 things is that you can change things through policies, legislation, and budgets. Those are the normal keys to change things. Very important when you're during your advocacy journey to stay positive, constructive, don't burn any bridges. Also remember that who you're trying to influence, if it's in government, if you're trying to attach your star to a minister or a deputy minister of health, for example, they usually only last about 2 to 3 years in those jobs on average. So you could just have done all the groundwork, and all of a sudden the personnel changes. The more important people to try to ally with and come to terms with are often the senior bureaucrats who've been there forever and will continue to be there forever, and often are the ones that will give advice to the deputies and to the ministers. It's important to cultivate the media. So I know when I was in Cape Breton, I'm sure Mike does the same in New Brunswick, when they want to come to you for a story that's important for them and they only have a 3-hour deadline and your office is busy, I often try to accommodate them as best I can, because if I have an advocacy project, I can call them up, and I've done them lots of favors, and they can help me out as well. Be prepared to compromise. That's important. Not your principles, but both the process, and it's about passion, it's about persistence and patience. And Will and Ariel Durant were husband and wife historian couple who, I remember wrote about 12 thick volumes of history. I didn't read any of them, but I did read the tiny little book at the end where they summarized everything up, and I remember that saying, which I think is quite apropos. Here again is Ingonish, up in Cape Breton, where we hiked and walked, and sometimes I lose a few golf balls, although I'm really not a golfer. So 3 cases. First case is municipal smoking bylaws. That may seem quaint now, but back in the 90s and the early 2000s, this was a hot topic. The effects of environmental tobacco smoke were becoming well known. Cape Breton had probably the worst smoking and cancer stats in all of Canada, and we know that tobacco addiction is a pediatric condition. 80% of smokers start before the age of 16. And when I first came there as a family doc in 1983, there was just smoke everywhere in the hospitals, everywhere. And then when I came back in 1990 as a newly minted pediatrician, I remember having to carry these little babies who were born prematurely from the surgical suites, and they might be 32 weeks and be gasping, and their lungs would be immature, and I have to run them down this long hall to our neonatal intensive care unit. And halfway down the hall was the family waiting room where everybody was waiting for the blessed new baby. But as I tried to go down the hall, there was this huge plumes of blue cigarette smoke coming out of the waiting room as the kid had a gasp in that. And so when I tried to suggest that maybe we take it off the maternity floor anyway, where there was mothers and babies, I had a huge amount of pushback, and this was just in the early 90s. But eventually we got the whole hospital smoke-free. And then in early 90s, we went before our municipal council. We found out who the opposition was. We found out who of the 16 members of council would be for a municipal-wide smoking bylaw that would ban it in restaurants, bingo halls, hospitals, public places. And we found out there was 4 people who were for us, there was 4 people who were against us, and there was 8 that were on the fence. And again, a lot of people in Cape Breton had smoked, and they were worried about votes and everything else. So we brought those particular 8 people in, and we had them meet with our cardiologist, respirologist, oncologist, and myself, and our administrator, our CEO. And we talked to them about what we were trying to do. But we also said to them, and I can remember our oncologist saying this, we said that, with one stroke of your pen, when you vote in a couple weeks, because this new bylaw was going to come before council, with one stroke of your pen or raising of your hand, the oncologist said, you can do more to prevent cancer in this community than I will do in my entire professional career. Well, you could have heard a pin drop when that came, and you could tell that really hit people hard. Just going to go down. So the strategies that we did leading up to it, we knew there was a 70% approval poll in the community. We had information packets. We had letters to the editor and editorials. As I said, we met with the municipal councilors. We found out who the opposition people were from the restaurants and the bars. And we also, family physicians would call their own counselors and let them know that they were for this as well. There was a council meeting. We had children with placards saying we want a smoke-free future, lining the hallway down to the council room. We packed the whole place with 50 healthcare workers in their whites and their stethoscopes. We made presentations before the council. And then remember how I mentioned earlier on that you should always tie personal story to the stats. Well, my Uncle Bobby was a veteran, worked in the Legions, and the Legions were quite against this. They said, we died on the beaches of Normandy, so we would have the right to smoke wherever we want. But he was dying of lung cancer from smoking, and I remember telling him about 2 weeks before the council meeting that I was going to do this. But one of the compromises we were going to have to do was that we were going to have a 2-year lead-in period where businesses could get used to it, and they'd eventually phase it out. And I said, what do you think, Uncle Bobby? And I didn't know what he was going to say to me. And he was yellow, and he's emaciated, and he had oxygen going on. And he looked at me and said, Andrew, why are we waiting 2 years? So at the council meeting, when the vote was about to happen, just when my presentation came up, I told the Uncle Bobby story. In fact, he had passed away a few days beforehand and was buried just a couple hundred yards up the street from the council room. Again, tying that human story, it was one of those, you could hear a pin drop in the room. because everybody has an Uncle Bobby, in Cape Breton anyway, and I'm sure elsewhere. So the nice thing is it passed 8-4, and we did immediate implementation, and the province then passed its own bylaw 3 years later. Our smoking rates have dropped, though, like elsewhere in the country, they're still stuck at 22%. So the battle isn't over, but it was a big victory. This also is in Ganesh, just to give your eyes a little break. And that whole idea about being prepared to compromise with things, the Rolling Stones, I think, said it best, for those of you who know the Rolling Stones. Steve Jobs also had this part, and about think different. And again, it goes back to that question, why not? The next case study I'll go through, and just one more after that, are youth health centers. Again, in Cape Breton, we noticed we had a large teen pregnancy rate. Probably about 20% of our pregnancies were young women under the age of 19. It was back in the early 90s. Obviously, there's evidence of harm for that. So we had an evidence-based, cost-effective solution. We had a working group. We realized that most of our teen moms went on social assistance at about $40,000 a year. We realized we could open up a fairly decent youth health centers in 4 of our high schools for about $320,000 a year. So we just needed to prevent 8 of the some 50 pregnancies or teen pregnancies that we had, and we felt that we could more than easily do that and plus save the government money. So they like to hear that part too. We visited around different health centers across the country and designed our own, where we had a secretary, a nurse there all the time, 5 days a week, and we have mental health coming in now, and also physicians visiting. And we had 4 open up, and now every high school in Cape Breton, there's 8 or 9 high schools in Cape Breton, all of them have youth health centers with visiting either pediatricians or family docs. And we have mental health, addiction services, group therapy, all sorts of things going on, and lots of kids coming. And we certainly dropped our teen pregnancy rate to a point where we weren't seeing them at kids at graduation anymore who are pregnant. And I think we dropped it by about 50%. I'm not saying that was all because of youth health centers. There may have been other factors over time, but ours definitely dropped down considerably doing that. And there was pushback on that, especially in terms of birth control pills being given out without parents' knowledge and all sorts of things that we had to go through. So, but we just persevered, and the nice thing is we had I'll just go back a slide. We had a very enlightened CEO who made sure that if the high schools provided the secretary and the space, the Department of Health through the hospitals would provide the supplies, and the nurse and the physician were able to bill sessional fees. So it was split between Department of Education and Department of Health. Last thing is Pee-wee body checking. What happened was, I'm an old hockey player and hockey coach, but the whole issue, as you know, with Sidney Crosby and others of concussions came up, and there was a good paper published a few years back, and it was actually published in November of 2012 as a position statement in the Canadian Paediatric Society's group on advocating for banning body checking in the Pee-wee hockey age, that's the 11 to 12-year-olds. There was evidence comparing Alberta, where they had it, and Quebec, where they didn't have it at that age, that if you extrapolated that across the country, it was probably about 1,000 concussions per year in this age group. 20% were serious, and that kids would have prolonged symptoms, more than 3 to 6 weeks of symptoms. So an evidence-based position statement was produced, and that's it from Kristen Houghton and Carolyn Emery. We had the evidence. And then what we did is that Calgary was able to, they failed a couple times, especially in Alberta, but Calgary was eventually able to get it done they had a local champion who promoted and got it done in early May of 2013. But there's a lot of pushback. Now, Hockey Nova Scotia was going to meet late in May of 2013, and a month later in PEI, they were going to have the Canadian meeting of all of the minor hockey associations. So we've got a team of experts together, including one of our neurologists, Dr. Kevin Gordon, who is a concussion expert, and some psychologists, myself, we spoke to it. We talked about in Nova Scotia, this would mean about 40 concussions a year, 8 of which were serious. But the key thing was, and this was a room full of kind of hockey coaches who all want their kids to make the NHL and feel like body checking is an important part for them to learn early. We had a very skeptical, rowdy audience. They had a new bylaw saying they're going to vote on it, that we would ban it, but it would take 2 years before we implement the ban. We had Paul from Hockey Nova Scotia, who's a friend of Hockey Canada, rather, was a friend of Sid Crosby. He was an inside champion, big former professional hockey player. He spoke to it. But my Dr. Gordon, our neurologist, brought one of his 12-year-old patients, Alex, who was out for 6 months after getting checked quite hard in December. And he got up and spoke, very articulate young man. All the stars lined up. He talked about how hard it was for his mother to see how worried he was about him. And just before the vote came, someone put their hand up and asked, what would it mean if we waited for 2 years like we're going to do to let PEI New Brunswick come on board? And I said, well, you'll have 8 Alexes every year for 2 years. That's 16 more Alexes. And they voted to go right away in Nova Scotia with a complete ban starting the next season. And then a month later, because Calgary and Nova Scotia had started with this, it started the momentum, and in June of 2013 it went across the country and they voted on it. So those are 3 case studies, and again, I'll just review very quickly. The focus goal, persistence, evidence-based approach, plus those human stories, find out who the decision makers are, who your allies, who the opposition are, be prepared for the pushback and the long haul. Stay positive and constructive. And remember that healthcare people, and one of our people who sat on the Advocacy Committee at the Canadian Paediatric Society for a number of years, Russell McCullen, a long-time Liberal MP and Liberal Premier of Nova Scotia, said, Andrew, you as pediatricians have a lot of untapped influence you can use. We listen to you guys and gals. So, be sure to use that untapped influence and persist, be patient, and be passionate. And I'll finish off by saying nothing in the world can take the place of persistence. Genius won't. Education won't. Persistence and determination alone are omnipotent. Again, another U.S. president. And that's the end of my little journey right now, and I will hand it over to my good friend, Mike Dickinson.
Great. Thanks, Andrew. Just give me a minute here to get organized. Andrew, always a tough act to follow. You had some beautiful summer scenes in your presentation, and the graphic that I chose to put up on my screen was inspired by the ice storm that we had here in New Brunswick a couple of weeks ago. And I know, Andrew, you guys in Halifax got just hammered earlier this week with a big winter storm. And to me, when I saw this graphic, it kind of reminded me that even when we're experiencing significant hardship and struggle, sometimes you can find significant beauty. My original plan was to start with this quote from Nelson Mandela, but every day I get a new motivational quote that comes into my inbox, and when I opened my email this morning, what did I find but a quote from Margaret Mead, who said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." And I thought that summarized beautifully kind of what we're trying to talk about today. My plan is to share a couple of vignettes from my own personal advocacy story, and interestingly, there's a lot of similarity and parallels to your presentation, Andrew, which will be kind of interesting to compare. And then at the end of that, I will talk briefly about a really exciting advocacy tool that was developed by the Canadian Paediatric Society, which is our status report, Are We Doing Enough? So I'm going to start with kind of a story, which happens to be sort of a smoking bylaw story that I call the saga of the smoking city councillor. And this took place almost exactly 21 years ago, and I remember it well because I finished my pediatric training in June of 1995 and started work as a young pediatrician in September of 1995. And it was just after Christmas when I had just started working when I was approached by a couple of my colleagues with the notion that we should approach our city council and try and lobby for a municipal no smoking ban in our own local community. And like you said, Andrew, back at that time, smoking bans were really the exception rather than the rule. It was the era where when you walked into a restaurant, the first thing they asked you was whether you want to sit in the smoking section or the no smoking section, which does seem kind of unbelievable from our perspective now. And as a new sort of young pediatrician, I was really optimistic about how this was going to go. I was optimistic because I knew that there was significant evidence supporting the potential medical benefits of a smoking ban, and that the evidence was really quite compelling. I was optimistic because I knew that I would get to focus on children and the effects of secondhand smoke on children. And anytime you can sort of weave children into your story and your narrative, that's always very powerful. And I was optimistic because I knew that one of the most senior influential members of City Council was a gentleman who had a tracheostomy. And I didn't really know anything about his sort of medical condition whatsoever, but I made the assumption that anyone who had a tracheostomy might be sympathetic to respiratory health concerns. And so we did our presentation, and I sort of, I think, passionately and eloquently talked about effects of secondhand smoke on children's lungs and coughing and wheezing and asthma, expensive medications, and parents' time off work. And then we were done, and there was kind of a brief moment of silence, and Councillor Dawson, who had the tracheostomy, raised his hand to speak and address council, and what I thought was going to be comments thanking us for our passionate presentation. And instead, he sort of went on kind of a 10-minute tirade on how, in his opinion, smoking was a personal choice, and how people have the right to make decisions about their own habits and their own personal choices, and how governments and municipal governments really didn't have any business at all interfering in those personal decisions. He spoke about how a bylaw would probably cause people not to frequent restaurants and coffee shops and bingo halls, and how that would be an economic disaster for the family. And then he, if that wasn't enough, he sort of finished saying that he didn't think that, he thought that the greatest threat to our respiratory health as a community was not secondhand smoke, nor was it the pollution billowing from the pulp and paper mills that were in operation at the time, but he thought that it was the remote automatic car starters that were quite popular at the time, people installing remote car starters so they could start their cars on a wintry morning. So in his opinion, it was the idling SUVs of local physicians that sort of caused the biggest threat to the respiratory health of our community. And so this obviously didn't go kind of as planned for us, and there was a little bit more discussion and a few questions, and then the motion for a smoking bylaw was soundly defeated, and we kind of slunk from the council chambers with our tails between our legs. A very different experience than you had, Andrew. But looking back on that experience, there were definitely lots of great lessons learned that I was able to take away and use on my advocacy journey. And certainly you definitely need lots of patience and persistence, and sometimes you don't always achieve your original objectives. I say first attempts often fail. I think fail might be, that word might be a little bit harsh, because oftentimes you kind of partially succeed, or you move the needle forward a little bit. So usually these aren't complete failures. And lots of times as well, you don't necessarily always recognize your success until some time has passed. And so I know in this particular case, although we didn't achieve our goal that night, the group of physicians that did the presentation, we were approached subsequently by some members of City Council who were actually quite sympathetic to us and supportive of a smoking bylaw, and we were approached by some community groups and members of our community who were also supportive of the cause, and that ended up leading to some really interesting and exciting collaboration and networking, which eventually resulted in a municipal smoking bylaw in our city. So what originally looked like a kind of total disaster actually sowed the seeds for future success. Clearly, at the time, I didn't fully realize or didn't fully appreciate the viewpoint of Councillor Dawson and many of the other councillors that were there at the time. And so while I'm not sure that anything that we were going to say that night was going to sway their decision, had I had a better appreciation of my target audience and their thoughts and beliefs, I think I would have framed my presentation to them differently. And so that was a really powerful lesson as well. And finally, I would say, I think as young physicians and young health professionals, I think it's easy to assume just because we've got the medical evidence on our side that that's going to be sufficient to carry the day. But I think you sort of summarized this nicely in your presentation, Andrew, that oftentimes the people who are making the decisions, while hopefully they're influenced by things like medical research and expert opinion, they're also influenced by things like public opinion and economics and politics, and that when we're engaged in some of these advocacy activities, we just need to keep that in mind. So that's my saga of the smoking city councillor. So my next little vignette, I call the Great Miramichi Chocolate Milk Riots of 2001, and this took place just a few years after the smoking bylaw issue. This was kind of around 1999, 2000, and I was approached to be a member of our local school board health committee, which was something at the time I really didn't even know existed, was not necessarily an area that I felt that I had significant expertise in. But I did know a couple of people who were on the committee and had great respect for them, and so so I signed on to be part of this committee. And it was an era where we were just really first beginning to fully recognize the enormity of the problem of pediatric obesity. And so this committee spent a lot of time focused on this particular issue. And we were very quick to realize that the school environment at the time was really not conducive at all to healthy, active living. It was tended to be a very sedentary environment in schools, and the foods that we were serving to children back in 1999, 2000 in schools were really a very poor nutritional quality. There were deep fryers in many of the schools. All of the schools had vending machines selling pop and chips and chocolate bars. Menus routinely included poutine, pogos, French fries, hamburgers, served on a daily basis. And there was even one school in one of our First Nations communities. Our First Nations population, of course, probably the highest risk for pediatric obesity. And they had a snack cart that went class to class, morning and afternoon, selling pop and chip and chocolate bars to the First Nation students in the school. And if you didn't have cash to buy your snack, that was okay. They'd run a tab for you. You could buy on credit, and at the end of the month, they would send the bill to the students' parents. And so we were really quite concerned about this, and what we thought we would like to do is we would like to develop a school board food nutrition policy. And again, sort of in 1999, 2000, this was before the era where school food nutrition policies were around. We really had few role models to lean on. But we wanted to move this forward, and we ended up spending the first year meeting with a lot of the different stakeholders involved, including the food service providers, the principals, teachers, parents, students, kind of appreciating their viewpoints on the issue. And we were really quick to learn that there was a lot of common ground. Everybody shared our concern about the level of pediatric obesity in our community. Everybody was in agreement that the quality of the food that we were serving to our kids in schools was of really poor nutritional quality. But the stakeholders also had kind of some interesting viewpoints, and they had their own concerns about and their own reluctance to want to make changes. The food service people were worried that making changes to the menu would increase their cost of production and squeeze their profit margins. The principals were worried that kids might not buy as much in cafeterias and vending machines, and that would cut off an important source of funds for extracurricular activities. Parents were concerned that the cost of meals might go up, and that might be a factor for some of our low-income families and students. All very legitimate concerns, all things that we took very seriously when we were developing our plan. And in the end, our plan was really very simple and basic. We took all foods and we kind of divided them into 3 categories. And if you think of it kind of like a stoplight, you've got your green light, red light, yellow light. And so we said our green light foods were foods that could be served in unlimited quantity and frequency, and that would include, or that included obviously fruits and vegetables, whole grains, lean meats were in that group. And then at the other end of the spectrum, we kind of had our red light group of foods, which were foods that we said should never ever be served in a school environment, and that included things, anything that would come out of a deep fryer, pop, chips, sugary drinks, things that we really didn't feel were appropriate for the school environment. And then we had this yellow group of foods that kind of fell in the middle, and these were foods that in our opinion anyway, maybe didn't have the best nutritional quality, but they weren't the worst either, and we thought that these were foods that could be part of a normal diet, but probably shouldn't be served every day. Therefore, they could be on the menu a couple of times a week. And it was into this middle group that we happened to lump chocolate milk. And so it was the school year of 2000-2001 that this local school board food nutrition policy was rolled out. And then we waited for the feedback and the pushback. And there were a couple of big surprises when we did this. And our first surprise was that we got almost no pushback whatsoever around some of the issues that we thought might be more sensitive. The deep fryers, the poutine, the French fries, the vending machines. We got almost no negative feedback on those issues. But the other surprise was that we got lots of feedback on the issue of chocolate milk, and so the phones rang off the hook. There were letters, there were emails protesting the fact that we had taken chocolate milk and limited it to only 2 days a week. And this came to a head on one day when our local school health nurse was going to do a routine visit to one of the local elementary schools to do some routine health education. And when she got to the front doors of the school, she was greeted by a grade 3 class that was there marching in protest with placards and signs protesting the fact that we'd taken chocolate milk off their menu. So that's what we kind of tongue-in-cheek refer to now to this day as the Great Miramichi Chocolate Milk Protests of 2001. And so we regrouped as a committee, and we looked at what we had achieved and the ways that the school menu had been improved. And in the end, we were willing to cave on the issue of chocolate milk. We thought that was a small price to pay in order to achieve a much healthier menu. And so we moved chocolate milk to the green light group and then carried on really without any significant pushback after that. And it was a couple of years later that our local Miramichi school food plan ended up being the kind of the blueprint for what would go on to be the New Brunswick school food and nutrition plan. So that was the chocolate milk riots of 2001, and again, when I look back on that phase of my life, I think there were some important advocacy lessons learned that I've carried with me over the years. Oh, I think I might have gone backwards there. Sorry, guys. First of all, I know I tend to be a little bit impatient, and I just kind of want to move things forward quickly and just implement the policy and get going. But the time that we spent kind of engaging the stakeholders and hearing their points of view was really time well spent. It's kind of akin to the know your target audience concept that we talked about in the first vignette. But that was a great lesson. And hearing our stakeholders, including some who were naysayers, actually turned them from kind of naysayers into allies in this partnership, and that ended up being very powerful for us as well. And kind of like the Rolling Stones quote, the fact that we were willing to be a bit flexible and give and take really put us in good stead with the people we were trying to advocate for change with, and showed we were willing to negotiate in good faith, and that I think helped us achieve our longer term goals. And so before I kind of move on to talk about the status report, I would just say kind of when I look back kind of on the early phase of my career, and I look back on some of these things like the school board committee, health committee, and the delegation to city council. At the time, these weren't really sort of things that I was particularly passionate about, nor did I feel like I had a lot of expertise in. But kind of early in my career, I ended up sort of saying yes to a lot of opportunities and committees, even though initially the benefits of being involved with these things weren't entirely clear. And when I look back on that strategy, now I kind of, as a new young physician and new young health professional, it was those experiences where I gained a lot of valuable advocacy experience. I had the opportunity to learn from people who were more experienced than I was with advocacy and health policy. And perhaps even more importantly, it kind of allowed me to build a network of contacts with people that I wouldn't necessarily kind of have contact with in my day-to-day workings, including people in the school district and public health and mental health and local politicians. And having made that connection and made those contacts has allowed me to engage those people ever since whenever there have been any other issues or concerns or advocacy issues to come up. So saying yes to lots of different things, even though the benefits weren't obvious to me at the time, ended up being a really helpful strategy for me as a new young physician. Sorry guys, I keep going backwards rather than forwards there. So finally, I'll just quickly summarize, and this is our Canadian Paediatric Society status report. It's called Are We Doing Enough? And we recently came out with a new iteration of this just last June in 2016. And in case there's people online that aren't familiar with the status report, what we do is we identify about a dozen issues that we feel are important to child and youth health and well-being. We choose issues that we think lend themselves well to advocacy efforts. And we choose issues where we already have a Canadian Paediatric Society statement and recommendations. And then once we've identified these 10 or 12 issues, we collect data from each of the 10 provinces and territories as to how well they're meeting the recommendations of the CPS. And then we publish them in this report. And it's ended up being a really powerful advocacy tool. And the best place to find our status report is on the Canadian Paediatric Society website, which is cps.ca. And you can access the data there in a couple of different formats. If you look at the bottom of this slide, you'll see immunization and smoking prevention. That's two of the 12 issues. And if you wanted to know how we do as a country in different jurisdictions on immunization, if you click that link, it would show you what that looks like. Maybe you're just interested in knowing how your own home province does on these issues. In the middle of the screen, you can see how you could click the tab for Newfoundland and Labrador and see how they're doing across the board on those 12 issues. So really user-friendly, very easy to use, very simple and elegant, but very powerful. I'm very proud of this slide. I created it myself. First time I made a word cloud. I might go out and have it framed when we're done here. And this just illustrates the 12 issues that were included in our latest iteration of the status report. And they include immunization, smoking prevention, breastfeeding promotion, newborn hearing screening, 18-month well baby visits, bicycle helmet legislation, booster seat legislation, ATV legislation, child and youth death review, type 1 diabetes in schools, and Jordan's principle. And just to show you before I kind of finish my presentation kind of what a typical page looks like, this is the page for ATV legislation, which you can see was in our 2012 status report and again in our 2016 status report. I decided to include this one in the presentation after a young man was stopped by police in Miramichi last week after he drove his ATV through the local McDonald's drive-through at 3 in the morning. And what particularly caught the eyes of the police was the fact that he was towing a couch at the time, including a couple of his buddies on the couch behind him. So clearly we have a little bit more work to do in the area of ATV safety in our province. Although I would say on a positive note, the two guys riding on the couch behind the ATV were actually wearing helmets. So maybe we've actually made some progress in helmet use for bikes and ATVs. So that's what a typical slide looks like. Recommendations, how each province does, and then at the bottom the criteria that we use to judge how each province was rated. I'll show you. This was a brand new issue in our 2016 report, and it's on kids with type 1 diabetes in school and their management. And you can see from the rating that's highlighted in blue that most of the provinces aren't doing a good job with this issue, and so we've definitely got some advocacy work to do on this particular issue, and I would be quite optimistic that when we review this this issue again in a couple of years that we'll see that we've made some great progress in that regard. And I will close off just by saying that, I think that each one of us can be kind of a beacon or a lighthouse in the area of child and youth health. And if we let our talents and our passions shine, that we'll certainly achieve our goals. And I love this quote from Nelson Mandela, who said, "A good head and a good heart are always a formidable combination," and that's sometimes all you need. So with that, I think I'll close off my comments, but I'm certainly happy to take any questions that the group might have, Doug.
All right, thank you very much. Two great presentations, some great examples of some successful advocacy initiatives, and perhaps some unintended consequences. We're so effective at helmet advocacy that people think they can, as long as they're wearing a helmet, they can do anything, I guess, maybe.
Exactly.
Yeah. So this is now your chance as the audience. If you do have any questions, any comments about your own experiences or about the report in general or how it's been used, etc., feel free to type those into the question box. One of the comments that came in was around, I can't remember if it was you, Dr. Link, or Dr. Dickinson. It was early in one of the presentations. You talked about, you sort of just made the comment that it's always great to bring in, a child. It's effective to bring in a child as part of the story. And sort of the comment was related to whether or not that's true, that is effective, and just specifically around the challenges of advocating for children's issues. Getting sort of lip service from politicians and policymakers versus actually children's issues really getting on the radar. When children don't vote, they don't have often don't have an effective voice at that level. So just sort of wondering, the comment was sort of related to how easy is it truly easier to bring in children's stories to tug at the heartstrings and have effective advocacy, or because they don't have a voice at the political stage, is it more difficult, just in your experiences?
Maybe, Mike, I'll take that one first. I think when I use the example of the concussions and the body checking, sometimes when you're doing advocacy, and you're effective, it's not anything you did. It just happens to be the stars lined up. And as Mike said, after a lot of attempts that didn't go so well in the past, but you have fertile ground, and then the stars line up, and our neurologist just happened to find this young man who happened to be super articulate and just hit every person in that audience who were sort of rough and ready coaches, and we lucked out. But we hoped it would have that effect, but we didn't really dream it would. But whether it's Uncle Bobby or Alex or it's the champion with the nun, you don't always know who the right people are going to be. But I can just tell you that nothing will make a room of decision makers' eyes gloss over more than if you're just doing the stats. Everybody wants to hear a story that they can relate to and hook on to, and we're human beings. We think with our brains and we think with our hearts, and it's just so important to do that. Obviously some people can overdo that and get funding for things that probably aren't the best choices either, by having a one-off case study. So you have to be a little careful, if I guess I was a decision maker, not to be overly swayed by somebody who needs $1 million for a new drug that will add too much to their lives, and they're 80 years old already. You have to be careful. But as Mike had alluded to, when it comes to politicians in particular, they work on 3 to 4 year electoral cycles. They want to get reelected for the most part, and they're very keen on public opinion, either one way or another. but the stories help break through that. So when it comes to using children, it's pretty unusual to be able to find a child spokesperson who would be willing and able and do a good job. But even relating stories in our own practices, and I'm sure Mike has many, as do I, when it came to kids we see, for example, with dental decay and caries who come from poor families. In Nova Scotia, they recently bumped up the age at which you can get free dental work from, I think, 10 to 15. And again, that was people, dentists and pediatricians and others, talking about stories they had seen in their own office and then actually showing the data. Mike, do you want to add to that?
Yeah, no, I think that's a nice summary. I mean, you and I, Andrew, sort of come from sort of small, working in smaller communities, and without a doubt, that sort of personal touch, well, it's important in any community. I think small communities where you know the families and you're likely to have a connection to the people involved. That really is a very powerful tool. I think you guys were really lucky to have that 12-year-old with the concussion issue. More often, oftentimes in the issues that I've been advocating for, the kids have been younger or haven't been as appropriate, but sometimes the parents, as a proxy for the child involved, can be very passionate advocates and tell their very personal story about their child and their struggles and how that impacts not only the child but the entire family. And so I've tended to have more success or with parents as opposed to kids, but certainly a teenage child who can speak to the issue would be gold for sure.
The next question that's come in is asking about how do you combat false information? We hear a lot about it today in today's news, so fake news and that sort of thing, but maybe the most sort of common example in our world is the whole autism and vaccinations issue. So when that information is out there and it's known to be false and it's proven false, but there's still that lingering issue and you're trying to advocate, say, for vaccination or something along that line, when there is that sort of false information out there, what are your strategies for sort of overcoming that?
Maybe, Mike, I'll take a first crack again. There are some people you are not going to convince with the rational facts. And I think when we came to, we were trying to push through the municipal smoking bylaw in Cape Breton. I think I mentioned to you earlier there were 16 councillors. 4 were dead against and 4 were definitely on our side. So we didn't spend a whole lot of time on either of those two camps, because we knew where they stood and we weren't going to change their minds. We didn't need to change 4 of them. It was the people in between that made a difference. Another time I presented to Municipal Council when I was also the acting medical officer of health in Cape Breton was to defend using fluoride in water, which has modest effects to prevent dental decay in poor people. And there was a chap, Paul Canet, Dr. Paul Canet, well known in the States, British guy, lives in the States, but he's an anti-fluoridationist, and he goes around to all the municipalities in North America when they're about to vote on this again. And he's always quoting these 20 studies that came from Iran and China about how deleterious it is to children's IQ. And that often would sway people. But I saw his presentation before I presented to our municipality in Cape Breton, and he was coming to it as well. But I got a chance to, again, understand the opposition. I went to YouTube. I heard about the studies. I got the list of the studies. I read them all myself, because one thing he would ask the health people in the audience at previous sessions, have you read these studies? And people, of course, they were in obscure journals. People would say no, which would hurt their credibility. So I read them all, and they were all terribly done studies, awful studies. So when the question came and I was ready for it, did you read these studies, Dr. Link? Yes, I did, and they're all terrible, and they don't show anything. And then I went on. So that was effectively able to silence him as opposition by doing that. Mike, do you want to add anything else to that at all?
Yeah, it's a tricky one for sure, and I think sometimes we make the mistake of assuming that these people are uneducated or that they lack information, but oftentimes these are people who can be very well informed and for whatever reason have chosen to believe in what we would consider very poor quality information And I always try to remind myself, I always try to treat these people with respect and show some sympathy for how it's easy to fall into the trap when you're surrounded by social media and news and books that kind of lead people towards this way. So I'll kind of acknowledge that information is out there, and that I can understand how people would come to that conclusion, and then I tend to sort of share my own personal opinion on the matter. I try my best not to make them feel stupid or uneducated. What I try to do is kind of engage them in a partnership so that they hopefully over time will kind of learn to respect and trust my opinion. And I think over time, if I can foster that partnership and trust and respect, then that sometimes leads to people moving towards an opinion that I share as well. But it takes some time, and it rarely happens in just one visit, and it often involves some back and forth. But I just try and treat these people with respect and acknowledge how easy it is to have these opinions, but then try to gain their trust over time.
And Mike, I think that was very well said. I mean, always stay on the high road, stay positive and constructive, and who knows, one of the people who might have been the biggest or one of your biggest people in opposition may, in fact, with time, be cultivated to become one of your biggest inside champions. So never burn bridges. I agree with you, Mike.
Yeah.
One question came in from Lisa. She's saying, in your experience, does drawing on success in other jurisdictions help persuade? So, this was the whole example of, well, they do it over there, so we should do it here. Is that often effective?
Sure, I'll jump in on this one, because that's really the whole premise behind the Are We Doing Enough status report that we talked about just at the end of my report. And it's a chance for people in different provinces to say, you know what, guess what, Minister of Health in New Brunswick, we're the only province in Canada that doesn't have a rotavirus vaccine. Look at our neighbors in Nova Scotia and PEI in Newfoundland. They all implemented it 3 years ago. How come you guys are so slow? And that kind of, I think, naturally competitive spirit that provinces have with each other has ended up being very motivating for change, and it's kind of what's made the status report such a powerful advocacy tool for us, is we've been able to hold up provinces who have fallen behind the 8 ball in certain issues and show them that other provinces are leading the way, and encourage them to catch up.
Has it ever
do you have anything to add to that?
No, I think you've said it beautifully, Mike.
I was going to say, has it ever backfired on you? I mean, I lived in Alberta for a while, and I can think of many instances where if we said that they were doing something in Toronto, that would not have been an effective argument for the folks in Alberta.
Yeah, you have to pick your jurisdictions that you compare with very carefully, for sure. So there's definitely some jurisdictions where that might backfire for you, but for the most part, I think most provinces are very sensitive to what their close neighbors are doing, and they don't want to be seen as falling behind. So maybe the Toronto example is a good one, but I think Alberta would be very interested to know what's going on in BC and Saskatchewan.
And the other point I would say to that is that sometimes if you're the first in the country or the province to do it, you should encourage people to be leaders. And every municipality, if that's the jurisdiction you're working in, or even province, likes to be known as a leader. Maybe some don't, but it's big kudos. And whenever I used to go back to the municipality to ask for other projects that we asked money for, and we were successful most of the time, I was saying, just remember, I'm so proud of you guys. You folks were the ones who took the lead on smoking and defended fluoride. This municipality has a great reputation as being a population health leader, and you can see everybody's chest sort of swell with pride around the council room. Yes, I'm patting everybody on the back, but they deserve the pat on the back, because they stood up for what was a good thing, and you let them know it. So again, they're human beings as well.
So they were the rebels that got us out of the caves.
Right.
We are just about out of time. I'll just take one more question, and then maybe we'll hand it back to each of you for any sort of closing comments. But the last question was related to, and you sort of touched on this, Dr. Dickinson, a bit. How do you bridge the gap in language when you're sort of a physician or someone from the healthcare community advocating to, say, the education sector, or to city councillors who are not medical experts, very likely have fairly low literacy in healthcare language and that sort of thing?
Right.
How do you bridge that gap without sounding condescending or what have you, paternalistic and that sort of thing when you're dealing with sectors outside of healthcare?
Right. I mean, I think that's a great question, and it is a fine balance. You don't want to talk over or under people's heads. You want to deliver a message that's sort of meaningful to them. And boy, I don't know if I've got any sort of great advice or strategy, but it is something that sort of comes over time, and I think you gain with experience. I think as health professionals, if anything, we sort of tend to perhaps sort of talk in a jargon that's a little bit technical, and reminding people to talk about personal stories and effects on people's lives probably means more to decision makers than the results of randomly controlled trials. So oftentimes we have to sort of dial things down, but you certainly don't want to dumb it down either. But I do think that this comes over time, and I think if you get to know your target audience, and certainly if you have a chance to sort of meet with people along the way, you come to appreciate what's the language that's helpful to them and what's the language that's meaningful to them, and it kind of comes naturally over time.
Yeah, Mike, I think that's well said. I mean, know your audience. And I think when it comes to using statistics and things, just be very careful, because not even well-educated people may not necessarily be numerate in the way we throw stats around sometimes. So put the statistics in a way that are clear and meaningful and easy to understand. And I agree with Michael, you don't want to be condescending, we want to be respectful, but I think it's respectful to always make things as clear as possible to people, no matter whether you're speaking to Nobel Prize winners or to your local municipal council. It doesn't matter. Know your audience.
All right, and I think with that we'll wrap it up. So, Dr. Lincoln, any closing comments, key messages you'd like to leave the audience with before we sign off?
Well, other than just, I encourage people to take these focus things on and be persistent. And Mike is our incoming president of the Canadian Paediatric Society, and he works with Maria Davis, our executive director. And they're always available for help if people are starting projects in the province or municipality for advice. And you just need to give us the office a call at the CPS in Ottawa, and I'm sure we'd find people or even members of our ACT committee will help anybody who's trying to advance a good cause.
And Dr. Dickinson, any closing thoughts from you?
Yeah, I would just say, I think a lot of really great advocacy work, I would say the majority of great advocacy work kind of gets done in the trenches below the, under the radar, and so it's easy to think that the advocacy work is being done by the people who are on national TV or who are good at public speaking, but that's not necessarily the case. I think a lot of it's done at a very local, quiet, grassroots level, and so I encourage people to engage in this kind of work because it's so rewarding, and reassure people that you don't have to be a great public speaker. You don't have to be in the limelight. You can probably be just as effective, if not more effective, just doing things at a local level under the radar, and so that there's a role for everybody in the advocacy world.
All right. Well, thank you very much. Great presentation, great conversation about some of these issues, and I think people are very appreciative of sort of the advice and the stories that will help them as they go and try to take on these endeavors in their own communities. And thanks again to the Canadian Paediatric Society for all of their great work and the Are We Doing Enough report. You can always go to their website and check that out, and I encourage everyone to do that. We do these webinars every Wednesday at 11 a.m. Eastern Time, and it's great when you can watch live, as the comments and the discussion and the conversation is great. But when you can't watch live, we do record these sessions and make them available after the fact on the Knowledge Exchange Network at ken.caphc.org. Next week, sort of along this similar vein, another report that certainly could be used for advocacy purposes, from the Canadian Institute for Child Health has a new module that's coming out about primary care reform, primary care services. And we'll be hearing Dr. Astrid Gutman and Shelley Callahan talking about primary health care reform and what does it mean for Canadian children and youth. They're going to be summarizing some of the findings from a CIHR-funded investigation and using some of the data that the CICH profile has produced around primary care services. So that will be a very interesting conversation there and probably of great interest to those of you who participated today. And then following that, on the very next day, Thursday, February 23rd, we'll be having part 5 of our 6-part Life with a Preterm Baby series that's been sponsored by Prolacta that we've been doing in partnership with the Canadian Premature Babies Foundation. That episode will be on sleep strategies for NICU babies and families, and we'll be welcoming Dr. Robin Stremler from the Hospital for Sick Children in Toronto to review the expected sleep needs and patterns across infancy, how to establish good sleep habits once home from the NICU, strategies to promote sleep for infants and parents, and safe sleep practices, and how sleeping and feeding interact at night. So again, that's part 5 of the 6-part series for parents and caregivers of premature infants. So as always, great stuff coming up, great presentation today. Thanks again to our presenters and to the Canadian Paediatric Society, and thanks to all of you for joining us today, and we hope to see you back here next week. Bye, everyone.